For centuries, the response to mental illness was institutionalization, an out-of-sight, out-of-mind approach. Institutionalization wasn't a solution. People who experienced mental health challenges were confined for long periods of time, some even for life, in psychiatric institutions. There were many reasons for this. Families often abandoned these patients because they were a great embarrassment, a financial burden, and source of anxiety. Drugs to treat and control mental disorders had not yet been developed, and so release into the community with medication to control symptoms was not an option. There were other problems with this approach: prolonged periods of restraint and solitary confinement, sensory deprivation, being cut off from one's family and community.
When we forget that people with disabilities share a common humanity with us, then the human is stripped from the human services, and the stage is set for the emergence of the inhuman and the inhumane.
A culture of abuse sometimes existed amongst those who worked in the asylums.
I lived in a situation where a number of my fellow patients were abused, both physically and psychologically, and I think that's because in that kind of situation the power imbalance is really significant. That is to say, the staff have all the power and the patients have none, and in those situations abuse often occurs.
One of the assumptions of the medical model was that mental health services were operated by professionals who know best. It was under this model that we saw the introduction of drug treatments. Psychotropic drugs were used to treat the symptoms of mental illness.
The real heyday for drug treatment came in the 1950s and has continued to this day. That was the era when we saw the introduction of lithium for bipolar disorder, of the antipsychotics, the early antipsychotic drugs, and a bit later drugs for depression. So drugs really became the main focus of treatment, and in many cases were considered miracle drugs, and as is the case with most drugs, the longer they're on the market, the more you see that they may be helpful, but they also have some downsides. The other risk is a central focus on drugs when there are other important kinds of support and treatment. I think the system as a whole recognizes that, but still the experience of many consumers is they largely get given the pills and sent home.
I was tied to the bed naked, and then they left me in the dark with these drugs happening that they had injected in me, and I was terrified.
Drugs are able to assist you, and they are more an aid to help you through things. I learned that you have to change yourself, too.
Electroconvulsive therapy and psychosurgery were also used to treat people with schizophrenia, depression, and other severe and persistent mental illnesses. Sociologist Irving Goffman claimed in his book Asylums that most people in mental hospitals exhibit psychotic symptoms and strange behavior as a direct result of being hospitalized. Counterculture author Ken Kesey's best-selling novel, One Flew Over the Cuckoo's Nest, is based on his experiences working in the psychiatric ward of a Veterans Administration hospital. Kesey's view? The patients he saw didn't really have mental illnesses. They simply behaved in ways that society is unwilling to accept. In the mid-1960s, the pressures of the civil rights movement, the drive for change by professionals, the discovery of psychotropic medication, and the cost of maintaining the asylum hospital system combined to lead to deinstitutionalization.
Deinstitutionalization is usually refers to a process of closing beds in the major psychiatric hospitals and moving people into the community. It started in Ontario and in most parts of Canada in the 1960s. It was very dramatic. We've closed over 80% of the mental health beds in Canada, even though the population has been growing since the 1960s. And really the hope was that people with mental illness could be treated in general hospitals, by their own family doctor, and the mental hospitals could be for specialized and more complex cases. The problem was that there was a serious underestimation of the kind of support people needed in the community.
Following discharge from hospital, people with mental health problems often lived in poverty, substandard housing, and isolation. they did not have opportunities or support to lead a dignified life with a reasonable standard of living, and they were frequently readmitted to hospital. In Canada, 35,000 beds in psychiatric institutions were closed over a 16-year period. Families were astounded to find forgotten relatives on their doorsteps. Deinstitutionalization led to a new set of problems because there was insufficient support for people with mental illness in the community. The first community-based mental health services came into being in Ontario during the 1970s. Treatments began to expand to encompass institutional services, community services, and rehabilitation programs. With the introduction of case management and assertive community treatment teams came more services in the community. However, these services were still operated by human service professionals with little or no input from consumers and little or no emphasis on peer support. Among the outcomes of deinstitutionalization was poverty.
I recall a friend of mine saying, they don't tell you that when you get out you're going to have no friends, no money, no job, and you're going to live in this crummy place. One of the huge difficulties of getting out of hospital is, depending on how long your stay in the hospital has been, you're likely to be absolutely disconnected from anything you're going to meet on the outside of the hospital. So your friends are gone and your family may be gone. You don't have a job. You're likely to be poor.
The 1970s and 1980s saw the beginning of a new vision of hope for recovery through community support. Part of that vision included the belief that consumers could support one another and create changes in the community and the mental health system. British Columbia led the way with social movement organizations like the Vancouver Mental Patients Association, or MPA for short. This organization came into being when patients who found their day program inadequate and who were dissatisfied with established psychiatric treatments developed an informal self-help network. Calling for alternatives, Vancouver MPA members operated with little funding and a lot of mutual support, circulating their phone numbers among members. In Ontario, as a result of reports such as Toward a Shared Direction for Health in Ontario, 1987, and Building Community Support for People, the Graham Report, 1988, funding was directed to the first consumer survivor initiatives in 1991. $3.1 million was to be committed to a special project of the Community Mental Health Branch. With a staff of 6, 3 consumers and 3 non-consumers, the Consumer Survivor Development Initiative began its operations in the spring of 1991.
We were lucky in that after the first year, we were able to secure some more money so that it went from being an employment program to a group development program and exists to this date.
By 1992, 81 full-time equivalent positions had been created by the projects, with a total of 307 people employed. 3/4 of this group had been on social assistance prior to this employment. In 1993, the Consumer Survivor Development Initiative became fully operated by consumer survivors. In 1996, the newly elected government released $23.5 million to enhance community mental health. This community investment funding led to the formation of 24 additional consumer survivor initiatives. The Consumer Survivor Development Initiative's role changed to support consumer survivor initiatives and build the consumer survivor sector. This provided key support for the reform process underway at the Ontario Ministry of Health and Long-Term Care. In 1998, the Consumer Survivor Development Initiative started an advisory committee that in turn evolved into a board of directors. And in 2001, the Consumer Survivor Development Initiative changed its name to the Ontario Peer Development Initiative and incorporated. There are now approximately 60 CSIs, each one different. In 1996, the Consumer Survivor Development Initiative conducted a survey and ran focus groups with the newly formed Consumer Survivor Initiatives. This research suggested that members were enjoying positive benefits as a result of this participation in these consumer-run organizations. Then, in 1997, a call for proposals for a community mental health evaluation initiative was issued. The research was to examine different types of services, including crisis services, assertive community treatment, consumer survivor initiatives, and family initiatives using a common approach. This community mental health initiative was coordinated by Dr. Paula Gehring and colleagues from the Centre for Addiction and Mental Health in Toronto. John Traynor invited Marnie Shepard, coordinator of the Consumer Survivor Development Initiative, Jeff Nelson of Wilfrid Laurier University, and Joanna Ochaka of the Centre for Research and Education to consider the potential of applying for a study of the Consumer Survivor Initiatives. Even in the planning stages, the study of the Consumer Survivor Initiatives used a participatory action research approach.
In this evaluation, we did not want to have only rigorous methodology, but we very much wanted a good process that itself was an outcome of this evaluation. We utilized participatory action research, research approach which is different than conventional paradigm of doing research. Participatory action research is rooted in the tradition of democratic pluralism, of empowerment, of social change, and evidence-based research. Participatory action research consists of maximal participation of stakeholders, of systematic collection of information and analysis of this information to inform future action and future change.